disclosures. So high pressure angioplasty has been around for 40 years. Ultra high pressure angioplasty for 20. And now it's become the standard. The instructions for use for the two big main DCBs are shown here. Both of them talk about high pressure angioplasty. This is baked right into the 2019 KDOQI, where it clearly says high pressure angioplasty. And the meta-analysis, we've talked about it a couple of times, talks about 11 studies using high pressure angioplasty. We talked about high pressure angioplasty throughout this entire meeting. This is the consensus panel that Rob Jones talked about earlier. You can see high pressure angioplasty, ultra high pressure, it's baked right in there. This is a big thing. Now, I think it's important to understand what we mean by high pressure angioplasty. There's been a very large sort of misunderstanding about this, that people thinking that high pressure angioplasty means that you always inflate the balloon to a high pressure. That's not the case at all. All we're doing is inflating the balloon to the pressure necessary to efface the waste, and that's it. In general, this often means that you're going way off label, sometimes using 50 atmospheres of pressure, but these balloons, as long as you're using an ultra high pressure balloon, are able to take that pressure. And we've known this for a long time. The basic assumption is that no residual stenosis is the goal. Now, we did talk a little bit yesterday about not always wanting that, and I'm going to set that aside for a second and say, as long as we believe that no residual stenosis is the goal, then the best way to do that is to efface the waste completely. That's part of the toolkit that I'm going to talk about here. And if we do that, then we should not have any difference in patency afterwards, and I'll show you the support for that. The central argument here is that especially fistulae require higher pressure to efface the waste than grafts, and you're going to need that high pressure to get that job done. If you use an ultra high pressure balloon, you can get it done essentially 100% of the time. The older technology did not do that. And the idea here is not that we're changing the shape of the survival curve, but that we're shifting it upwards and thereby increasing the success rate for our patients. So when we looked at this, and back in 2005, our population was mostly grafts. Still, we hadn't changed over. Now we're way, way over the other way. We're 60% or 70% fistulas. And as you can see, even at that time, in our smaller native population, there was a statistically significantly higher percentage of the time that you were going to need over 20 atmospheres of pressure. And more than half the time, you needed over 15 atmospheres of pressure in both grafts and fistulas. Tom Vesely looked at this in grafts and found that 30% of the time you needed pressures over 20 atmospheres. And they stopped at 30, which we don't do. We go as high as necessary. And when they did rupture, there was actually a problem with that. These were lower pressure balloons, and they resulted in venous ruptures that required stents. So there was a disadvantage. Just an example here. Here's an immature fistula with a swing point stenosis, unable to efface the waste at 30 atmospheres. About 40 atmospheres, able to efface the waste, no problem with an ultra high pressure balloon, and a good result. Now, technically, this is important because I keep seeing pictures of inflators. I haven't used an inflator in over 20 years. You don't need an inflator if you're using an ultra high pressure balloon. I think Jerry Beathard taught most of us that you can use a polycarbonate syringe, use a 10 mil syringe to fill the balloon, a flow switch, block the flow switch, switch over to the 1 mil, and just using your thumb, you're generating 50 atmospheres of pressure. So as long as you're using that ultra high pressure balloon, it's no problem. And the sizing, as you can see here. And then we talk about these other tools, prolonged angioplasty, by which I mean 5-minute cycles, as well as progressive oversizing of the balloon. Our endpoint is physical examination, supplemented by flow measurement when needed. This is Dhiraj's paper, and I think this one at least partially settles the argument where some people have said that using high pressure consistently, which we're not doing, by the way, we're using it selectively, might decrease patency. And in this study where they looked retrospectively at patients that were treated with higher pressure balloons versus lower pressure balloons or mid pressure up to 15, again, only going up to 30 atmospheres though, the success rate was the same, and I would argue that if they'd gone beyond 30, their success rate with the ultra high pressure would have been even higher. But importantly, the patency was not different. So this study helped address that question. Interestingly, this paper had a lot of grafts, which I thought the Canadians had a lot of fistulas, but I don't get that one, Dhiraj. So I think that this shows that ultra high pressure does not decrease patency, and there was never any claim made that high pressure angioplasty changes the shape of the curve. All we're doing is we're raising the curve overall. You do have to use the tool correctly, and I think this is important. And many of you have seen this series of images. You can see here a patient with a basilic vein transposition presenting with an abnormal exam with pulsatility. You can see there's a tight swing point stenosis which measures greater than 50%. So it meets the criteria for treatment. starting with an 8 millimeter balloon, which one might say is a little bit undersized, but in this case you can see there's very significant residual stenosis after angioplasty, well over 30 atmospheres needed to efface the waste. Progressive oversizing now to a 10 millimeter balloon, again, greater than 30 atmospheres needed to efface the waste. Still 56% residual stenosis if you measure that. You don't want to eyeball these things. And then after now using our other tool of prolonged inflation, so a couple of 5-minute cycles of prolonged inflation, now we have a less than 30% residual stenosis. That's a good angioplasty. That's using all the tools. High pressure balloon to get over that waste, to get the waste effaced, and then prolonged angioplasty, and then progressive oversizing as needed. So when we did the Keidoki, hello, okay. Can you stop the clock since the slides are stopped too? We're dead in the water here, folks. Well, what I was going to show you is that when we put the Keidoki together the first time in 1997, we thought we were setting a pretty high bar of 50% primary patency at 6 months. And we all said, we're putting angioplasty out there. We need to make sure that we're really, putting it as a high bar. We also put surgical revision at a high bar. And we thought, okay, that's pretty good. 50% 6 months. And if I could, I would be showing you now a lot of science. We've heard all this science here throughout these 2 days. We've heard about all these randomized trials in fistulas in which core lab adjudication was done with careful measurements in randomized studies. And I'm going to talk about the control groups. Because in these control groups, doing good angioplasty with high pressure balloons, we've been able to achieve patencies of, the first study I was going to show you is the recent Chinese study, 80% primary patency at 6 months, not 50%. If you look at the impact study, 68.9% primary patency at 6 months, as opposed to 50% suggested by the Keidoki. If you look at the Lutonic study, it's in the high 60s, again, way over the expectation. The only place that and here we are, so we can catch up now. So here's the Chinese study I talked about, 80%. Here's PAVE. You can see about 70%, 6 months, way over the Keidoki. Here's the impact study, way over the Keidoki. Here's the Lutonic study, way over the Keidoki. That doesn't apply. and so here, though, this is not all the way across the board. You just saw this slide, okay? This is the Avenue study. And here, where that toolkit was not used, guess what? The primary patency is not even as high as the suggested Keidoki recommendation. In fact, if you look at the treatment arm, it more or less matches that of the control arms of all the studies that I've just. So what's different there? Bart tells me this is real world. I say, Bart, it's not my real world. Sorry. So in conclusion, high pressure angioplasty is now the gold standard. It's part of a toolbox. You have to use all the tools to get this kind of result. If you do, you're going to get great results for your patients, and importantly, you don't need to use any more pressure than needed to efface the waste. Thank you so much for your attention.